Hi, everyone. Welcome to our April case conference. I'm Tua Pal, and I just wanted to go through some housekeeping first, and then we will get started with our exciting lineup of speakers. So just again, we appreciate everyone that has been referring to ICARE. We have both our online referral form as well as prepaid postcards. Again, we're continuing to exceed probably 80 referrals a month to ICARE, or 80 consents. So again, we thank you for your engagement. Other thing I wanted to ask folks to do is submit interesting or complex cases for participation in ICARE. And again, we have an exciting lineup for speakers or guest experts over the course of the remainder of the year. Here are some resources that we provide through ICARE. As you all know, the case conference. We have a newsletter that we publish biannually, our website, which is searchable, so has the information that we have publicized on our social media, also on our website in a searchable format. And then we are pretty active on social media. And again, these are just some of the posts that we posted over the course of this past month. So we post about talks, newsletters, open studies, stories that are educational, research updates, as well as guideline updates. Just wanted to put in a last pitch for this HBOC conference, which is early next month, May 6th to 9th in Montreal. Again, one of my favorite conferences, happens every 2 years, organized primarily by Dr. Will Fowkes in Montreal. So again, if anyone is interested, either attending online or in person, it's still available. Also wanted to let everyone know that we just finally released our spring newsletter. So that is now on our website. We will be sending it to our provider partners. Again, just highlighting the growth of ICARE. We're almost at 7,500 participants. You can see across various different genes. We're recruiting anywhere between 70 to 85 participants a month. And again, you can see the growth, and we have gone all over the place. So across the US and beyond. So in our newsletter, we have a bunch of policy and guideline updates, including, some of the minor updates, I would say, for NCCN, both genetics panels. The big one here, I would say, is prostate is now part of our breast, ovarian, pancreatic, prostate, which we had a lot of prostate content, but now we are officially we have officially added prostate to it. But again, you can see all of the various policy and guideline updates. We have a bunch of articles on cancer risks, BRCA1, BRCA2, CHEK2, Lynch syndrome, etc. And then research efforts that we have highlighted within the context of our newsletter as well. So please check it out. We have an amazing community spotlight. Someone by the name of Sarah Kavanagh, who is the founder and host of the Positive Gene podcast. So I would check it out if you're interested. But again, she tells about her story in her journey through inherited cancer. So again, it's a great write-up. So with that, I am going to get started with the first case, which was a patient I saw within the last few months. So this is a 42-year-old female with an MSH6 mutation. So here you see the proband. The mother with breast cancer was the first one to be identified in the family. Her middle full sister right here is negative. And oldest sister, who is, her maternal half-sister, is reserved about whether she wants to find out. And then again, there's a number of family members in the maternal lineage that really haven't pursued the testing. And this is the details I have listed of the specific variant. So what I did was I just Googled this variant, but again, like I was looking it up in ClinVar, but what we found was ConnectMyVariant came up as the third hit, which was really exciting to me because I became familiar with Dr. Brian Schertz's work, who is our guest expert today, a few months ago, around the time we were trying to recruit him to Vanderbilt. He is now at Vanderbilt. He's been here since December of last year. But again, so what I ended up doing was touching base with Brian, who again said, yeah, we do have someone with this variant in our database. And this was of interest to my patient because she, first of all, she wanted to be sharing the information with her family members. She wanted an effective way to be able to communicate this information, but also just the genealogy part of it was of interest to her as well. And I think Brian will give you more information about this, but again, it kind of shows you the value of this resource. So during the appointment, this I pulled directly from my note, we discussed there's a website, ConnectMyVariant, through which you may be able to connect with others that have the same variant as you. I reached out to the founder and he let me know there's one other person in the database. If interested, check it out. And if you have any questions or trouble, I told her to reach out to me, but hopefully she has registered. So what, like this again brings up this issue of family communication and testing, which has really been at the crux of Brian's work and his efforts in pushing this type of effort forward. So in my after visit summary, I've started to incorporate ConnectMyVariant language uniformly because I do think this is something that some patients are very interested in learning about and registering in. The other thing I would say, and again, this is work that myself and Debbie Cragen and Marlia Kritzel have kind of led through one of our clinical trials where family communication and testing is hard. And sometimes people think that it's just this one time we're going to share, but it isn't that easy often, where it's this ongoing sort of effort that needs to be revisited continuously. So again, we were in the process of analyzing our data, but we've had some interesting findings as well. And then the other resource that I really wanted to highlight that, again, I've been really impressed with is this series of family gene share videos that's developed by the founder of My Faulty Gene, Kathy Baker. And I, again, would encourage you all to check this out. It's familygeneshare.org. And it's just short gene-specific testimonials on individuals with various inherited cancer predisposing genes. And they are super duper impactful and they're educational and they're accurate at the same time. So again, another tool to to give to patients who can then send these videos that are publicly available to their family members to show a story of how knowing about inherited cancer can be really important both for an individual and at-risk family members. So with that, I wanted to go ahead and introduce my colleague, Dr. Brian Schertz. He's going to focus on his effort that, he founded, ConnectMyVariant. He's an associate professor in the Department of Pathology, Microbiology, and Immunology at Vanderbilt, as well as biomedical informatics. And he's the service medical director for molecular genetics laboratories. Many of you may know Brian from when he was at Washington University, but like I said, we were able to recruit him to Vanderbilt in December. So he is now part of our organization. So with that, Brian, take it away.
That's a wonderful introduction. And we have ConnectMyVariant has a three-part presentation. I'm going to give a short overview of what it is. And then I'm going to have my friend and colleague Rachel Pearlman, who's at the Ohio Genetic Counseling faculty at the Ohio State University, talk about one of the families that inspired me and that really led to founding ConnectMyVariant. And then we're going to hear a patient story. as well. So what is this? Right now, it's a 501c3 nonprofit organization. It started as a research project from about 6 years ago, and the mission of the nonprofit organization is to end hereditary disease by bringing families together. It started out to end hereditary cancer, but we have people with cardiomyopathy and hypercholesterolemia variants today. They need to family outreach with us as well. It's entirely focused on hereditary disease outreach and family outreach. There's many other organizations, many other resources that frankly do a much better job at giving information to patients who want to know what they should do for themselves. And we're not trying to duplicate what they're doing. So we're really focused on hereditary outreach. So our key, here we go. Sorry, our key activities are working with patients to implement personalized family outreach plans. We have about 20 volunteer family outreach navigators, and their job is to meet people where they're at and help those people talk to the next person, the next logical person, take the next step of talking to their family members. We also facilitate extended family networks and variant-specific communities, sharing prevention stories. 90% of the time, if two people have the exact same mutation, then they inherited that from a common ancestor. And just knowing that makes people realize that they should be talking to beyond their first-degree relatives to maybe their second and third-degree relatives. We found that if you have two people who have the same variant, introducing those two individuals increases family outreach activities by 2.5-fold. That was what the initial research project showed. And we also have professional genealogy assistants to help people. We also do some interactive workshops to train patients about how to do family outreach. And then we've always had an equity and inclusion emphasis so that we can build partnerships with others to promote family outreach. So those are the key things that ConnectMyVariant does. You can see them here in this little chart. We have this individual family outreach navigation that provides individual help and longitudinal check-ins. We have this genetic education. A piece I didn't mention is the monthly newsletter. That's actually really valuable to remind people on a continuous basis that they should be doing this family outreach, provide stories, to provide tips and tricks, the social interactions, connecting people so they can share their stories. They can have what we call, when we have multiple people with the same variant, we call it a variant family reunion. That's a term that I didn't coin, but other people said, oh yeah, we're all together, we're all cousins. And then this big pedigree building, and the BYU Center for Family History Genealogy are our genealogy partners. We also try to partner as much as we can with patient advocacy groups because we know we're just focusing on the family outreach, and we want to partner with other groups that can do the patient education about what they can do next when they have a diagnosis. So this is slides to show how ConnectMyVariant is different and how we're not what you might think we are. We're not a research project. We started out as a research project. We haven't been one for many years. This is a public health initiative. So when somebody signs up, they're not giving research consent. There's a button they can check to say they're interested in research, but this is something that is beyond that. There's lots of research projects that try to connect people. Most of those are for rare diseases, and most of those are entirely researcher focused. We saw that there was a need to be patient focused and not researcher focused, and family focused and not kind of focused on getting the next grants. So this is a public health initiative. It's really family outreach focused. That's all we do. We're an educational organization, not a healthcare organization. So we rely on your clinic, if you're a clinician, to do the treatment and to do the genetic counseling and to order the testing. And we rely on other organizations to provide education for people about what the next steps are once they get diagnosed. It's personal and longitudinal. It's not a one and done thing. Many of the interventions that have been developed for cascade assistance are things where, let's make it easier for you to talk to your first degree relatives. What we've seen, and then one of the master's students did a project with ConnectMyVariant at the very beginning, interviewed people to see what success looked like in terms of family outreach. And the really successful families, it was a nonlinear, multi-year process. And so we want to facilitate that and make sure people can do that rather than try to find a one and done solution. All of these, the solutions that I've listed are all great. I really appreciate anything that lowers the barrier for people communicating with their families. But we want to provide that. And then we provide genealogy assistance. And as far as I know, I don't think anybody else is even thinking about this. This is something that's really unique to ConnectMyVariant. So we're starting to partner with health systems. And the reason why we want to do that is we want to be able to have contracts with health systems to be able to provide family outreach assistance to people in that clinic. And so if you're on this and want to have a specific sign-up page for ConnectMyVariant for your institution, then send me a message afterwards and we can talk about how that would happen. But the goal with that is to really focus on the communities that are served by a health system to really work in an integrated and comprehensive way so that over the years, we'll be able to reach a large portion of individuals in a community. And that's where it can be really effective. And Rachel's talk is going to show you how it can be effective to find people in the same community that have the same variant. This is what it looks like right now. The research project started in 2019. In 2021, the research project ended because we had too many people saying, "Where have you been for the last 5 years?" And it transitioned to and then it was a public health initiative within the University of Washington for a little over a year. It launched as a nonprofit organization in 2022. We started training the first family outreach navigators in January of 2023. And today there's over 1,700 people that have enrolled. Our enrollment has grown by about 5% a year. I think that's largely because people are really interested in this. This is something that is powerful and meaningful for people. So I am going to, here's our board of directors. Our board of directors is half patients and family members who are interested in this. And we also have some professional people who do nonprofit businesses and genetic counselors as part of our board of directors. So I'm going to hand it over to Rachel to tell her story. And there'll be time for questions afterwards. I know some people have questions, but I want to make sure we hear Rachel's story first.
Thanks so much, Brian. For those who don't know me, my name is Rachel Pearlman. I'm a genetic counselor at the Ohio State University Medical Center. Thank you so much to ICARE for having me come and talk today, and particularly to Brian for asking me to share a very special family with you all that we collaborated on many years ago. I'm really passionate about cascade testing and happy to share some pearls with you about extreme cascade testing utilizing a public genealogical database. So the story starts with the Ohio Colorectal Cancer Prevention Initiative Study, or OCCPI. This is originally why I was hired to work at OSU 12 or 13 years ago. The James was wanting to create a statewide network that would include both academic medical centers, large hospitals, and community hospitals to really establish a community network and research infrastructure. And we also wanted to establish the prevalence of hereditary colon cancer at that time. And so we created this statewide network. Any person who was diagnosed with a primary invasive colon adenocarcinoma who had surgical resection in Ohio during our 4-year study period was eligible. And that at OSU only, we also included a cohort of endometrial cancer patients. We enrolled over 3,300 colon cancer patients, 342 endometrial cancer patients. And at the time of enrollment, we did collect first-degree family history information. All patients on study received mismatch repair tumor screening, and all of our patients with mismatch repair deficient tumors received germline multi-gene panel testing. Cascade testing, so many opportunities for future research. Of the 154 individuals identified on the study with Lynch syndrome, 66% had at least one relative participate in cascade testing. I worked very hard to cascade in every family. And, as we've already heard and already know, cascade testing can be really tricky and really challenging for a number of families. If you eliminate the families that we didn't have any cascade testing, and we had 6 patients tested per proband, which, is pretty good. But I did have one gold star family that I was able to test 148 relatives. So I'm going to share how I did that. And it starts with EC1. who was from a small town in Ohio, diagnosed with endometrial cancer at age 44, and she enrolled into our study in September of 2013. Her tumor screening was discordant. She had an MSS tumor with isolated absence of MSH6. And we did our germline genetic testing through the University of Washington, which is how I got connected with Brian and also Colin Pritchard, who's the director of the lab there. And she was found to have a VUS, variant of uncertain significance, in MSH6. We also did tumor genetic testing to try to determine if maybe she actually had double somatic mutations. We found that she had one pathogenic mutation plus an MSH6 somatic MSH6 VUS in addition to her germline VUS. So, we didn't know which VUS was pathogenic, so we weren't able to, clarify her case that way. Her maternal aunt had ovarian cancer and died at 44, and a maternal grandfather had colon in his 60s. So I had counseled her to follow Lynch syndrome guidelines. And I didn't think much about her for a few years until CRC1 was enrolled into our study from a small town in Ohio. He was diagnosed with colon cancer at age 42, and he enrolled into the study in April of 2015. His tumor screening, we weren't able to do MSI. He was diagnosed at stage 4, so he just had a small tumor from biopsy. He was absent MSH2 and MSH6. And we did his genetic testing through the University of Washington as well. He had a VUS and MSH6. You may notice that VUS looks familiar. I didn't connect them at that time. I thought, maybe he was, could have been double somatic MSH2, but we weren't able to do tumors genetic testing for him because of his small biopsy. He did have a family history of cancer. His dad had he reported a cancer site unknown in his 40s, prostate in his 60s, paternal grandmother had ovarian. His mom had endometrial cancer, and a maternal uncle died of liver cancer, which I was convinced was a young onset colon cancer. And his maternal uncle had, another maternal uncle had an abdominal cancer and passed away. And then I realized that these MSH6 VUSs were the same. And I think I have this funny ability to remember variants with certain patients. So when you stare at a spreadsheet for 10 years looking at these different families and mutations, you kind of remember who has what. And I thought, all right, well, perhaps they could be related. And then I realized that they were from the same small town. So I pulled their pedigrees that I had ascertained when I was counseling them, and their standard pedigrees did not show that they had any sort of relation to each other, but I thought, same VUS, same small town, they've got to be related. I'm not really sure what caused me to think to do this, but I had an Ancestry.com account, and I had used it really for myself for many years. And if you're not familiar, Ancestry.com has wonderful resources, historical records. So I use birth certificates, marriage certificates, death certificates, census records, immigration records. They also have member trees. So, people will go in and create their own family member trees, which many of them are public, and that can be used as clues as well. And so you can see here, and sorry that some of my pedigrees in here are going to be hand-drawn. I didn't have time to put them into Progeny, but you can see this picture. So this is the floor of my office with a 12-page pedigree that I worked on trying to connect everything together. And my suspicion was confirmed, sort of. The probands did link to a common ancestor from Glandorf, Germany from the 1800s. And I linked them as fifth cousins. And I was so excited. I remember calling Brian and Colin and saying, oh, fifth cousins, this is going to reclassify it, right? And so, we were like, yeah, and it was, upgraded to pathogenic, knowing that they're linked through fifth cousins, and, we could start doing cascade testing for relatives. So I called my colon cancer proband first. He was the one that I had spoken to most recently. And I said, hey, great news. And as part of the study, I would go down to the local hospitals and do really large family sessions. So I had him bring his, his siblings, his parents, and I was so convinced that this mutation came from his mom with her endometrial cancer that I said, bring a bunch of your maternal relatives. So he brought like 20 maternal relatives. And, you know, when I was sitting there and talking to this family afterwards, the patient's father came up to me and he's like, you know, I think I'm related to them as well. And I was like, oh, okay. And he's like, you know, I had a grandmother who had that same last name. And I'm like, okay, you know, sure. You know, but your wife has endometrial cancer. There's all this, you know, likely, you know, young onset colon cancer in the family. Like it's going to come from her. And he's like, no, like, let's test me too. And so I said, okay, I, you know, consented him, got a sample, and the mom was negative and the dad was positive, which is exactly what he told me was going to happen. So his parents are actually fourth cousins, and the VUS then linked to my two probands as third cousins. And I was so nervous when I had to call Brian and call him, you know, with my tail between my legs, sort of. And I was like, oh no, like, does this change the classification? And thankfully it does not. I don't know if you're all familiar with Brioni Thompson, but she published a paper in 2013 talking about co-segregation analysis and this full likelihood method. And it showed a 2,328 to 1 likelihood supporting pathogenicity still. So thank goodness. And so at that time, I started cascading through this family. And I started with my colon cancer proband, and you know, there was one thing in this family that really allowed me to have a lot of success, and that was my patient's paternal aunt. She actually tested negative for the variant, but she was the family historian and such a genealogy buff. And when I met with her, she was really excited about this, and she called literally every single person in her family that she's ever met and said, you need to get tested for this. And that was a huge help. So, you know, there's only so much that our family letters can do. So if you can identify the family historian and get their buy-in, that makes a huge difference. And because of this, we ended up getting 3 additional branches of the family to test. And one of those branches, we identified the mutation of 100-year-old unaffected woman. When I actually tested her. So, you know, it was a huge help. I probably wouldn't have been able to do this without her. So my proband's brother was also positive, and I told him obviously at the time he needs to go get a colonoscopy. And he did, and he ended up having an early stage colon cancer. And thankfully he's doing well now, but I really feel like this work, you know, that we did trying to get everything reclassified and doing this cascade testing, ended up saving his life, because he knew his brother had an early stage colon cancer and didn't have a colonoscopy at that time. But once he knew that there was Lynch syndrome in the family and he had it, and after having genetic counseling, he went and got his colonoscopy. So it really does make a difference in these patients' lives. Sadly, my colon cancer proband is now deceased, but I do still talk to this family regularly, as you know, his children have aged up and other children in the family have aged up. They still come back for testing now. And with my endometrial cancer proband, this was also an interesting way that the family communicated. So they actually had a private Facebook page. I wasn't even aware that this was a thing, but they had a family private Facebook page that they would share information through. And so, you know, they would post when I would be coming to their small town to do these family sessions, and I would show up and have like 30 or 40 people there waiting for me, you know, to get their free genetic testing. And that was something that we offered through the study. So we got a ton of people that way as well. And I recently had somebody email me out of the blue saying, you know, I'm looking for Rachel Pearlman. I think this is you. In my family Facebook page, I found that I could have Lynch syndrome. I don't even know how I'm related to this person, but, you know, should I have genetic testing? And so even now, this was, you know, very recently, it still is making an impact in this family. So I would certainly consider this successful cascade testing. These two seemingly separate families had 20 and 29 first and second degree relatives respectively, that were ascertained from a standard 3-generation pedigree that you would take in clinic. But once I linked them as distant cousins, 6 additional branches of third cousins were identified, with hundreds of at-risk relatives. And then I was able to identify fourth and fifth cousins using Ancestry.com, and thousands of at-risk relatives were identified. When I pulled this for an abstract in 2021, we had 148 tested at that time with 52 positive, and a whole other branch of the family with the mutation was identified. But there's still lots of people in this family that probably have not been notified, that need to be. And I think that this certainly can be a new approach to cascade testing. I will say it is very time consuming, and had I not been solely doing research at that time, probably wouldn't have been able to do this. We had 25 repeating mutations throughout OCCPI, and I connected 12 other probands this way, utilizing Ancestry.com. This process obviously can significantly increase cascade testing and assist in variant reclassification by identifying the furthest common ancestor. It's a ripe opportunity for future research on how to alert distant relatives of their risk, and ConnectMyVariant is certainly a great resource for that. So I'm happy to take any questions now or later, and if you're also welcome to email me down the road. Thank you so much.
Thank you, Rachel. That was really impactful. That's a really, really neat story. Anyone have any questions that they want to? And Brian, I don't know if you had any comments about.
I have comments that are going to lead on to the next slide. So I'll wait for others to have questions first.
Okay, I don't see any in the chat. I don't see anyone with their hand up. So keep going, and then we can.
I can ask my question. So my question for Rachel, which I'm going to answer, is, this is amazing. And so when I saw Rachel do this, the question I had was, why isn't everyone doing this? I asked Mary Claire King, have you ever seen this? And she pointed out, she went through her records and found that she had actually connected about a dozen second cousins, and found a median of 12 relatives testing positive after those, and connected 3 third cousins at about 40, the median of about 40 people connecting because of that. And so talking to Rachel and Mary Claire King made me think, why aren't we doing this in a bigger way? Why can't all patients do this? I want to let you answer Stephen White's question, and then Rachel, will hand it back over to me if there's another question.
Okay, so the question is, was any consent required to use Ancestry DNA?
I don't know if anything was actually required. I didn't save anything. So the way that all of the information that's in there is publicly available. Like, you can Google and get some of this information. So there wasn't anything that was obtained that, anyone else couldn't obtain, just from looking into these things, and nothing was saved anywhere. So, I don't think there was anything that was needed. Well, hopefully not. But, if somebody knows more, that's, would love to hear.
I can tell you how we do it with ConnectMyVariant now for people who are doing it. So people are signing up independently for ConnectMyVariant and agreeing to share their contact information with other people who have their exact same mutation. So they're consenting to share that contact information. And then there's a separate kind of consent to when they start working with the BYU Center for Family History and Genealogy. And this isn't research consent, but we do want to make sure people understand what they're getting into. And when the BYU group does it, they make private pedigrees for individuals, so they're not connected up with like any other linked pedigrees anywhere. And they're only providing those directly to the people who they're working with that variant. So.
And another thing I just wanted to clarify too, are all of the patients that we counseled on study signed release forms to share information with their blood relatives. So the share, when I told them that they were related to each other and linked, like, we had consent to share that information from each of the families. We didn't provide any DNA information to Ancestry. It was strictly used as like looking up birth certificates, marriage records, immigration records, that type of thing, to be able to like link them on a pedigree in my office.
So Rachel, we have a few other questions. They're kind of related. So one question is, many patients are concerned of their privacy selling data by direct-to-consumer laboratories and other. Some do not want to learn of other relatives, e.g. finding a half-sibling they did not know about, etc. Other question is, does Ancestry.com provide training for healthcare providers to use this resource? My guess is, I think you'll answer it, but probably not, and you were figuring it out yourself, but I'll let you answer it. How did you specifically initiate the conversation with the relatives you found on Ancestry.com? There's another question, but let me just stop there for a second to let you respond.
Okay, so that is a lot of questions.
Selling the data is the first.
I did not receive any training from Ancestry.com, and I don't know, I don't think that they provide training for healthcare providers, but you know, if a healthcare provider has the time to sit and do this, you know, training would certainly be helpful, although it is, I think most genetic counselors could do this. It's pretty intuitive of how to use it. How did I specifically initiate the conversations you found on Ancestry? So I did not directly reach out to any of the relatives identified on Ancestry. That was all done through the family members who I spoke with, which is why there are still hundreds and thousands of relatives who have not been notified of this variant. So like for my colon proband's family, it was that paternal aunt that I spoke with her, and she's the one that called all of these relatives, and then just word of mouth through the relatives is how, and they called me and said, hey, my relative said I need to have testing for this. And for each relative enrolled, they all signed consent to share their information. So that's how we were able to get it. I didn't do any direct outreach myself to anyone that I found on Ancestry.
I can tell you how, and this is on the ConnectMyVariant website if you want to go find it, but the instructions we give people when they're doing those conversations that work really well is to say, first you approach people about your relationship. You say, oh, I'm a descendant of Adela Cowley, and I know you're also the grandchild or great-grandchild of Adela Cowley. So you acknowledge that relationship, and then you say, why you looked into it. I have a lot of breast cancer in my family, and I don't know if you had anything about that, and then listen to what they say to their response, and then say, well, we think we know why there's a lot of breast cancer in their family. It's because this genetic mutation, and I wanted to contact you to let you know about it because that might be something you want to get testing for. So those are the kind of 3 or 4 steps we say is first talk about the relationship, then talk about your experience in your family, and then talk about the mutation. And that seems to have gone over really well. And then people know what you're talking to them because you found them in Ancestry because you're your common relatives. And people are on Ancestry because they want to talk to their relatives about their ancestors. And so that's worked really well for us.
And so there's another question here. Sorry if I missed this, but I'm curious what the uptake rate was among these families. How many completed testing versus all the relatives who were notified? Also curious what method of contact were used to notify relatives: call, email, text, social media. You kind of covered this, Rachel, already, but I'll let you answer that to see if there's any other details we missed.
Yeah, I probably could find the actual uptake rate if I went through, at least for like 1st and 2nd degree relatives. It would be pretty easy for me to do that. I have not done it, so I don't know the number off my head, but it was extremely high. Like I have almost all of the at least 1st and 2nd degree relatives of these families tested, and most of the 3rd degree relatives on the affected side of the families as well. I don't know exactly if there were relatives who, family members had contacted and they declined at that time. I don't have all of that information. So mostly just the ones that I've spoken with, and then maybe they decided not to test. That doesn't happen very often. And methods of contact use. So for me, I only really spoke to them by phone. But I know that they did use social media. This family used social media to contact family members, and I'm sure they emailed, texted, and called as well. but I didn't do like provider mediated direct outreach, to like random family members, 3 generations up. That was not something that I did as part of the study.
Yeah, and you know what, Rachel, the other thing I would say is you made it easy for people, right? Because the counseling, they could come when you went to that hospital and you did group counseling sessions, and then you just drew their blood and there was no cost to them. There weren't, like, sometimes I feel like there are a lot of barriers for people to get the testing, right? Whether it's cost, whether it's appointments, whether it's lack of appointments to move forward, et cetera. So it's a really neat concept.
It's also true that it's very difficult with these big families to know exactly how many people got follow-up, because they could have got follow-up somewhere else. And so it's anything, your estimate is an underestimate by definition. And how much of an underestimate is it's hard to say. I don't see other questions. I'd like to move forward with the next slide, because the question I have is it possible for someone that's not Rachel, the amazing Rachel Pearlman, to do this? And let's see if the video will go.
Hi there, my name is Leanne Seddon, and I am a teacher librarian by day and a so-called genetic genealogist by night and on the weekends. I'm also a previvor of hereditary breast cancer, and today I want to share with you just a little bit about my progress working on my family tree and ConnectMyVariant to help spare lives from hereditary cancer. All of this work is an effort to just help pay it forward, because my life's been spared too. It all started in 2017. In February, my big sister was diagnosed with breast cancer. She was only 39. And because of 4 other breast cancer cases in the family, she had genetic testing in May, and it came back for a variant on the PALB2 gene, and the variant is listed there. At the end of May, she met with a genetic counselor, and I went too. And at the end of the session, I asked for testing. My gynecologist had talked about testing and said he would recommend it, so I knew there'd be no problem about getting that approved insurance purposes wise. That summer, so my big sister completed chemo, had her mastectomy, and started radiation. Early that summer, I got my results, and of course, I have the same PALB2 variant, and it came on the day of my sister's last chemo treatment. So I waited to tell the family till the next day, but then I also signed up for Ancestry.com immediately, and just because I wanted to map our family tree and figure out where this variant, or at the time I didn't know about the variant, where this PALB2 mutation came from, and more importantly, who else might be at risk. And so mom tested negative that summer, which we suspected, and our third sister also tested positive. So, it's just kind of against the odds that all 3 of us inherited this from our father, but that's how it was. And it's just part of our story. And he also tested positive for it just a couple years ago. But then in October, our middle sister was diagnosed with breast cancer too, and she was only 38. It came a couple weeks after the big sister finished radiation. I had gotten a second opinion saying, yes, preventive mastectomy is the right way to go. And then she's diagnosed. It's just kick in the gut, but it was because we knew about PALB2 and because of genetic testing that hers was caught a little bit earlier than Becky's. And I should say that my sisters are doing very well today, blessedly. So it's a good story now. But November, she had her mastectomy and started chemo. And then I had my preventive mastectomy in December, and on the 20th, right before Christmas. But I just wanted to get them off, ticking time bombs, get them off. And on the 26th, my pathology came back clear. And it was just the best Christmas present ever for me and the entire family to not have to endure another diagnosis and treatment. So knock on wood so far. After that, though, I joined PALB2 Warriors on Facebook, and it was a small group at that time, only maybe a few hundred people. And in continuing my genealogy and building the family tree, reaching out to family members, I created this medical family history that you see on the screen. Noticed lots of cancers on one side of the family, and then found some on the other. One distant cousin even had metastatic colon cancer and had testing, but was negative for it. And even doing ancestry DNA, which I eventually did, nobody seemed to have this PALB2 variant that I talked to. Anyways, in March of 2018, I came across my genetic test report, and I posted in the Facebook group asking if anyone else had the same variant. And that was just like a huge revelation, like this light bulb moment, because people didn't realize that there were so many variants of PALB2, and that if you found someone that had the exact same one, they were likely to be family, somewhere down the line, and possibly you could find a common ancestor and then be able to forewarn the others who could be at risk. The first one I found was Nita, and she actually created a poll of variants in that group. And to this day, I'm an admin for the group. And in my weekly posts, I encourage new members to look at that poll, read about variants, and direct them to ConnectMyVariant, if they want to get help from the professionals. And that's what I do now. But back then, when I first posted, I hadn't known. It was not until the fall of 2019 when I was looking at my genetic test report in a little more detail and noticed those PMIDs with the other cases and looked into the studies. I emailed Mary Claire King's lab, or her, at University of Washington, and told her what I was interested in doing. And Dr. Schertz responded the very next day. And this was just like, ecstatic, because I found someone who had the same mission as me. And it was just the start of many emails and Zooms, informing and educating me about some genetics basics and how to better use Ancestry, MyHeritage, and other sites. Then the genealogist at BYU helped even more, kind of to verify the accuracy or inaccuracies in the family tree that I had built. And that was so helpful too. In this next slide that I show you, they helped create a document and found the living descendants of these people and contact information so we could reach out to them and forewarn them. So this shows that family. They are from Appalachia, and the first one that I touched base with was Margaret. And back then she didn't have breast cancer. Today she does. And I sure hope she's doing okay. She's 80-some years old and was diagnosed with breast cancer just last fall. But her family is enormous. It's riddled with cancer. Some have had cancer, but not the variant. I met one lady, connected with her, and she and her mom actually have a different PALB2 variant. I don't know of any cases of Fanconi anemia in their family, but that's known now. And I've added a dozen or so to this family since then, and hopefully we can reach out to more of them to help save their lives. But I think a lot of them already know about it. In 2020, I met Claire through the Facebook group, and she joined ConnectMyVariant, had a DNA test on Ancestry, and it came back and said we were 5th to 8th cousins. So we know we had a common ancestor somewhere along the line. And then in the research and through Facebook and ConnectMyVariant database, several others joined and doing lots of research and genealogy work, and finally found a common ancestor in this John Michael Bates. He was born in Baden-Württemberg, Germany in 1743, immigrated with his parents as a young boy, died in 1801. Like I said, we've have added all of these people into the family tree. And one of the cases is a success story. I reached out to a gal, and she had saw my message for one thing, and had some family history of cancer and responded. I gave her the variant information. She got genetic testing and she has it, but she can have the screenings, so she knows about it, and she's still a provider today. So that's fabulous. Another lady breaks my heart because I had sent a message. She never responded. And a lot of times I don't hear from people. And she didn't get tested because she thought she was healthy. But then the next summer, she was diagnosed with breast cancer. And, she admitted that she could have avoided all the pain and suffering and of that chemo if, she'd have done something. So, but maybe someday we'll be able to prevent the breast cancer by knowing about our variants. And so I had this Appalachian family tree and this South Carolina based family tree looking for connections. And a few years ago, I might have found it. It still needs verified, but found some names and, searching in the family trees, and it goes back to Germany, possibly to this Johannes Betz. And so that right there is, I believe there are 14 generations, and that only shows the known cases of cancer. Who knows how many others are out there, but there are undoubtedly lots of other descendants that could be affected. And that's why we've got to do this work with ConnectMyVariant and just reaching out to family members to help save the lives and spare them from hereditary cancer. And so today I still am working on my research and looking for and making connections. I don't know if I'll ever find where I fit into that Bates family tree. I have my doubts, but still I work at it and persist, just knowing that my efforts with ConnectMyVariant and reaching out to people won't be in vain, that we are working to try and spare lives from hereditary cancer and hereditary disease. Thank you.
That's the end of that story. I think that this is this is really an exceptional story, and was one of the I was very, very fortunate to meet Leanne right when the research project was starting, and this really is, I think, exceptional now, but we're seeing it happen more and more often in ConnectMyVariant. So I'm happy to look at more now. I think that's the end of our presentations. So yeah, there's our kind of funders and supporters. Yeah.
So Brian, I have a question for you. Actually, it's both for Brian and Rachel. So in the real world, like when we are seeing our patients, like in the US especially, it may less so the case for other countries, but we have a very fractured healthcare system, right? Where, our insurers aren't necessarily incentivized to promote cascade testing, family sharing. We as providers believe in it because we see the public health importance of it. But from a system level, there are some barriers / challenges. Like, what are your thoughts on, and I know that through ConnectMyVariant. That's kind of, I mean, I would think that that's part of the goal, to overcome some of these barriers or help people, like empower people to be able to move forward. But just any thoughts about that? Like, would family sharing or family testing look different in other countries versus us, and how to deal with this fractured healthcare system, which is, probably not going to change anytime soon?
Gonna go first, Rachel?
Sure. I mean, I'm thinking of it from like a cost perspective. I think as far as like a fractured healthcare system goes, and I know that, even clinically now, when all of these different labs offer free family member testing for 90 days or 150 days or, whatever it is, there are still many, many, many people who do not take advantage. So I don't know that it's actually cost that's a barrier for all individuals. Certainly getting the screenings, if you find out you're positive, are also very difficult to do, for people that have insurance or high deductibles or whatever. So I don't know that I have the perfect answer for it, other than it is hard and challenging. And I think
Yeah,
there's
I don't know the
probably more
answer.
barriers as well than just the cost, as seen by these free family member testing programs and little uptake.
Yeah, and that's something I agree. I haven't been able to solve, and I'm not sure what the answer is. I know Australia and New Zealand are like way ahead of where we are in terms of promoting this type of family outreach. I do know that the having groups of people talk to each other really does help. People learn about different pathways, and I've seen families overcome really extraordinary barriers. One of the stories highlighted on the ConnectMyVariant website is Joanne, and her family's from Trinidad and Tobago, and she's found relatives in New York and Los Angeles who have her Lynch syndrome variant, and they've been reaching out to people in Trinidad and including like trying to figure out how to get the family history done and how to get genetic testing done in Trinidad. Like, I have no idea where to even start there, but they do, because they know the resources that are available there, and they know what resources or how the family can come together. So it's been incredibly impressive for me to see families overcoming barriers by talking to each other and working with each other. That's not the best solution. I would love to have a more universal solution, but I've seen people figure it out for their own families.
I will say, like, telehealth has certainly increased, even like in my own clinical practice, significantly. And I think part of the reason for the success in these families was that I was going to them, in their town. We would meet at like a local hospital or a library or whatever, and we'd do these information sessions there. That was really before like telehealth genetic counseling was as commonplace. But now when you can send somebody a kit and you can talk to them on the phone and do everything on their lunch hour, that makes it certainly more accessible too.
Okay, I know we're almost at time. Again, thank you so much, Brian and Rachel. And, the patient story, again, so impactful. And again, I applaud you for the work that you all are doing. And, we're thrilled to have Brian here at Vanderbilt so we can contribute to some of the work that he's already gotten started. So with that, we have some upcoming guest experts that will be presenting in our case conference. So in May, it will be Antonis Antonios. He is the developer of CanRisk, which is a program that many of us use to estimate risks for breast and ovarian cancer. Potentially soon prostate cancer is going to be added to that. So encourage folks to attend this one. If you have cases, and again, this happens through our own clinical practice where we come up with a case, like an estimate that doesn't really make sense. So Antonis is willing to kind of go through some of those cases, and I have a bunch saved for him, but if anyone has any that they'd like to present, please feel free, and I can kind of displace mine. For our June case conference, it will be Joanne Katsopoulos, who's done a lot of work on hormonal risks, with hereditary breast and ovarian cancer, mainly BRCA1, BRCA2. Another thing that I see very commonly in my practice is HRT following risk-reducing oophorectomy, especially in younger women. So that is something that Joanne is actively working on that I think, again, is of definitely high interest to me because this is something that patients face frequently where should they take hormone replacement therapy, like what is the data? And again, I would argue that there is data to support that many times it's safe. Here is a list of our upcoming ICARE case conferences for the rest of the year. They're also listed on our website. And with that, I thank our guest experts again, and thank you for attending. And we will be in touch. And again, with ConnectMyVariant, you can also, I'm sure Brian would be completely open to anyone reaching out to ask for more information about ConnectMyVariant. So thank you,
Yes.
everyone. Thanks for attending.